Hello, and thank you for joining today's webinar, Preparing for Pediatric COVID-19 Immunization and Adult Booster Doses. We are pleased to bring you this webinar at an exciting time in Canada's COVID-19 vaccination campaign, with vaccine for children aged 5 to 11 rolling out imminently across the country, and booster doses becoming available for those previously vaccinated. My name is Katie Rutledge-Taylor, and I'm a nurse manager at the Public Health Agency of Canada. We are pleased to collaborate with CANVax to provide webinars on COVID-19 vaccines for healthcare providers. Before we begin, we would like to acknowledge that I'm speaking to you from Ottawa, which is the ancestral and unceded territory of the Algonquin and Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. Now I'd like to introduce and welcome our speakers for today's webinar. Dr. Bryna Warshawski is a medical advisor with the Public Health Agency of Canada, working on the rollout of COVID-19 vaccines. She is a past chair of the National Advisory Committee on Immunization and is cross-appointed as an adjunct assistant professor at Western University. Bryna will be providing an overview of the Pfizer-BioNTech vaccine for children 5 to 11 years of age and its use and administration, as well as timing of the concurrent vaccination programs that are underway this fall and winter. Next, we'll hear from Dr. Catherine Burney. She is a registered clinical psychologist, assistant professor at the University of Calgary, and associate scientific director of Solutions for Kids in Pain. Katie will be speaking to us about management of vaccination pain and fear in children. And finally, we'll hear from Ms. Alexandra Nunn, who is a nurse epidemiologist in the immunization division at the Public Health Agency of Canada. Alex will be walking us through some models for vaccination clinic operations and considerations for their use. None of our presenters have any conflicts of interest to declare. And now I will pass the floor to Bryna.
Thanks very much, Katie, and it's a pleasure to be with you today. So what I will go over with you today is some information about the Pfizer-BioNTech vaccine for the 5 to 11-year-olds, and also talk a little bit about the adult booster doses as well, and how the pediatric campaign and the adult campaigns may overlap. So to start with just a bit of background about the pediatric population. In Canada, we have 4.7 million children between the ages of 0 and 11 years, and they represent about 12.5% of our population. If we look specifically at the 5 to 11-year-olds, which is the topic of today, they represent 2.9 million children, which is 62% of the population less than 12 years of age. Okay, now we're going to talk about the burden of COVID-19 in children less than 12 years of age. So we'll start with the green box. Here you see the number of children who have had COVID-19 over the course of the outbreak on the left-hand column, and the number of children who have been diagnosed with COVID-19 in October. Now, this is an underrepresentation because we know that children tend to be asymptomatic, and so they may not be diagnosed and may not be reported. Under the numbers, you see the rates of COVID-19 in children less than 12. So there have been over 200 per 100,000 children less than 12 diagnosed with COVID-19 over the course of the outbreak. But on the right, you can see that in October, that rate has almost doubled to 400 per 100,000. And this is a fact related to the fact that the Delta variant, which is quite contagious, has been circulating in that population. The black box shows you the number of children who have had serious outcomes. So we've had 1,076 children with COVID-19 hospitalized. There have been 129 admissions to the ICU. And unfortunately, there have been 11 deaths over the course of the outbreak in children less than 12 years of age. So turning now to the blue box, here we see of all the events that have occurred throughout the course of the outbreak, what percentage have happened in children less than 12? As a reminder, children less than 12 are 12% of the population, and they've represented 11.3% of the cases of COVID-19 that have been diagnosed throughout the course of the outbreak. So pretty similar to their percentage of the population. But on the right, you can see that in October, they've represented almost 24% of the cases that have been diagnosed. And again, this is a function of the fact that the Delta variant has been circulating in this unvaccinated population. And in the maroon box on the right, you can see that this is of the children who are less than 12 who've been diagnosed with COVID, what percentage of them end up with serious illness. So about 1 in 800 children about 1 in 180 children who have been diagnosed with COVID-19 end up in hospital, and about 1 in 1,500 children who have been diagnosed with COVID-19 end up in the ICU. So again, this represents the fact that children can end up with serious illness. It's not as common as in older adults, but children can end up being hospitalized, can end up in the ICU, and unfortunately can end up very rarely, but can end up dying from COVID-19. So not a totally benign illness in children less than 12 years of age. At the bottom, you can see the number of children who have been diagnosed with multi-system inflammatory syndrome in children. This is a rare complication that can be serious that happens a few weeks after the COVID-19 infection. So in children less than 12, up until the end of October, there have been 227 children diagnosed with multi-system inflammatory syndrome in children. And in fact, children 5 to 11 tend to be the most frequent age affected by this syndrome. As well, we know that children can develop long COVID or post-COVID syndrome. These are symptoms that can last for weeks to months after their original infection. We don't know how frequently that occurs, but we do know that it can happen in children. So with that background about burden of disease, we'll now talk about the pediatric formulations that are available or that we expect to be available. So the Pfizer-BioNTech vaccine for children 5 to 11 years of age was authorized for use on November 19th. This is a 10 microgram formulation of the product. So as you know, the adolescent formulation is 30 micrograms. For the 5 to 11-year-olds, it's a 10 microgram product. And in order to provide that 10 micrograms, the manufacturer has created a new formulation. So this formulation, which has an orange cap, as you'll see, allows it to be easier to draw up the 10 micrograms, which ends up being 2 milliliter that are put into the syringe. The additional change is that in the adolescent formulation, there's what we call a phosphate buffer, but they've changed that buffer in the pediatric formulation to something called tris sucrose. And what that does is it provides an added advantage to the pediatric formulation in that it can now be stored in the refrigerator for 10 weeks. The adolescent formulation can be stored for 31 days, but the pediatric formulation now has a number more weeks, so 10 weeks in the refrigerator, which makes it a lot easier to manage in terms of storage and handling. Now, we do know that the manufacturer is also working on submitting for authorization for the younger age group for 6 months to less than 5 years of age. And that's expected sometime at the end of 2021 or into early 2022. And here it will be a 3 microgram dose, so even smaller than the 5 to 11-year-old dose. On the right, we see the plans for Moderna. Moderna has submitted for authorization for the 6 to 11-year-olds on November 16th. For Moderna, they will use the current formulation, but the dose will be half the dose that's used for the adult and adolescents. So adult and adolescents, we draw up 100 micrograms or 0.5 mils. For the 6 to 11-year-olds, it will be 50 micrograms or 0.25 mils. And similar to Pfizer, Moderna is also working on a product for younger children, 6 months to less than 6 years of age, and that's expected sometime in the new year. So now we'll look a little bit more closely at the Pfizer product, and we're going to compare it, the adult-adolescent formulation, which is in the middle column. We're going to compare that to the pediatric formulation. So I'll just call the adolescent formulation the adult formulation for simplicity. This is the product we use at 12 years of age and over, and it has a purple cap on it. It will also in the future have purple stripes on the label. Not every vial will have that, but eventually we'll see purple stripes on the label. The pediatric formulation for 5 to 11-year-olds is orange cap and orange stripes on the label. The diluent for both products is the same. It's the diluent provided by the manufacturer, but in the adult formulation, you add 1.8 mils of diluent, and in the pediatric formulation, you add 1.3 mils of diluent. The dose that you draw up for the adult formulation is the 30 microgram dose, and so that's 0.3 mils. And for the pediatric formulation, the 10 micrograms is 0.2 mils. Both are 2-dose schedules. For the doses in the vial, using a low dead volume syringe, for the adult formulation, you can get 6 doses out of the vial. And in the pediatric formulation, you can get 10 doses out of the vial. As mentioned, there is a different buffer in the pediatric formulation. That's the tris buffer, and tris can be an allergen as well. So we know that the polyethylene glycol is the same. That's an allergen in both products. And the tris or tromethamine or tromethimol, a number of different names, that can also be an allergen, very rarely, but just to know that as well. The next difference is once you puncture the vial, so the first puncture for these products would be when you add the diluent. Once you puncture the vial, the adult formulation should be used within 6 hours of that first puncture, whereas the pediatric formulation, you get 12 hours after that first puncture. There are also differences in the storage and handling. So for the storage for the adult formulation, it's held ultra frozen, and the ultra frozen period at which it expires is written on the label. For the pediatric formulation, what's written on the label is not the expiry date, but the manufacture date. And so you need to add 6 months to that to know when it actually expires. The next difference is that the adult formulation can be held frozen, so at -25 to -15, whereas the pediatric formulation cannot be held in a regular freezer like that. Finally, the other big difference that we noted before is that the adult formulation can be held in the refrigerator for a month, whereas the pediatric formulation can be held in the refrigerator for quite a bit longer, for 10 weeks. And one other thing to note, that at room temperature, the adult formulation can be held 2 hours before you puncture it and 6 hours after you puncture it. For the pediatric formulation at room temperature, you have 12 hours before you puncture it and 12 hours after you puncture the vial. In terms of transportation, the adult formulation can be transported ultra frozen or frozen. The pediatric formulation, because you cannot put it in a freezer, it can only be ultra frozen. However, both can be transported in the thawed state as well. The adult formulation only for 12 hours, and the pediatric formulation as long as required and as long as you're within that 10 weeks that it can be kept in the refrigerator. So now we'll turn to look at the clinical trial, and this is the information that that Health Canada looked at to authorize the vaccine. So it has a few parts. The first part is the safety of the product. So originally, in the first safety cohort that was studied, there were 1,518 children who received the active vaccine, and they were followed for a median of 3.3 months after the second dose. Subsequent to that, another cohort was added. This is another cohort of 1,591 children receiving the active vaccine, and this is to add some additional information about safety. This cohort has been followed now for or at the time of authorization for 2.4 weeks. So a shorter period of follow-up for that second cohort, but in total, over 3,100 children who have received the active vaccine as part of the safety. The study also looked at immunogenicity and efficacy, and we'll turn now to look at the results of those various parts of the study. So first, in terms of the safety, as mentioned, 3,100 children receiving the active vaccine, half followed for 3.3 months, half followed for a median of 2.4 weeks. In the trial, they compared some of the safety parameters to an older group, 16 to 25 years of age, who received the 30 microgram product. And basically the safety profile in the children 5 to 11 and the 16 to 25-year-olds were quite similar. There was a little bit more local reactions like swelling and redness in the younger children. Pain was fairly similar between the age groups, but the younger children, the 5 to 11-year-olds, had less systemic reactions. So they had less of the fever, tiredness, headache than the 16 to 25-year-olds. In the trial, there were no serious adverse events noted and no myocarditis noted. But we should note here that this was a fairly small sample size to look at a rare event like myocarditis. So in 3,100 children, we wouldn't expect to see myocarditis necessarily, even if it was occurring, because of the sample size being fairly small. And we don't know whether myocarditis will be a safety concern in this population. We know it's happening in the adolescents and adults, but we don't know whether it will be a feature of the vaccine in the 5 to 11-year-olds. We'll be monitoring that post-marketing. The next thing that was studied was the immune response. And here they used a technique called immunobridging. So basically what they did here is they compared the immune response in the 5 to 11-year-olds who received the 10 microgram dose to the 16 to 25-year-olds who received a 30 microgram dose. And you can see here that the immune response was very similar in those two age groups. We know that the vaccine works very well in the 16 to 25-year-olds, and because the immune response is very similar, using immune bridging, we would be able to say that we expect that the vaccine would work similarly in the 5 to 11-year-olds. And in the trial, they were actually able to show some efficacy results, and they found that based on preliminary information, the vaccine efficacy against symptomatic disease was 90.7%. So this is really quite similar to the efficacy that was seen in the older age groups in the original clinical trials. So very reassuring that we will see good efficacy from the vaccine in the 5 to 11-year-olds. So now we'll turn to the advice that's been provided by the National Advisory Committee post-authorization of the vaccine. So NACI has indicated the vaccine may be offered to children 5 to 11 years of age, and they've recommended an interval between the first and second dose of at least 8 weeks. So this is consistent with the advice that was provided for adults and adolescents, that an 8-week interval be provided between the first and second dose. And the advantages of this is that we know that in adults and adolescents, a longer interval leads to a better immune response and better effectiveness. And we expect that that will be the case as well with the 5 to 11-year-old vaccine. In addition, we know that a longer interval between the first and second dose seems to result in lower rates of myocarditis in adults and adolescents. So it's possible that if there is a risk of myocarditis in this younger age group, and again, we don't know if that will be the case, but we may be able to mitigate that further by having this at least 8-week interval between the first and second dose. The next recommendation by NACI is that as a precaution, they've recommended not giving the 5 to 11-year-old COVID vaccine with any other vaccine on the same day and leaving a 14-day gap between the COVID vaccine and any other vaccine. This is different than the adults and adolescents, where we have said that you can give any vaccine together on the same day or separated apart. You don't have to have any separation between the COVID vaccine and other vaccines. For the pediatric vaccine for the 5 to 11-year-olds, they are recommending a separation between COVID vaccines and other vaccines. And this is a precaution to avoid any confusion between potential side effects. Again, we don't know that there'll be any concerns about side effects, particularly in this age group, but if there are, we want to clearly know whether that's related to the COVID vaccine and not confuse that with other vaccines, and hence this precaution of separating out the timing of the vaccines. Of course, that wouldn't apply if you needed to use the vaccine on another vaccine on an urgent basis. So if you'd just given the COVID-19 vaccine and you needed to give a vaccine for post-exposure prophylaxis, you would still go ahead and give that other vaccine as needed. So NACI has also provided advice with regard to children who have had previous infection, saying that you can offer these children the COVID-19 vaccines as we've done with adults and adolescents. That's once they're no longer infectious and their symptoms have resolved, and they may be offered 2 doses with at least an 8-week interval. This recommendation for previously infected children and adults is under review by NACI, so we'll watch for future updates on that advice. Specifically with regard to children who have had multisystem inflammatory syndrome in children, NACI has recommended that they may be vaccinated as well once their symptoms have resolved and at least 90 days has passed since their diagnosis, whichever is longest. Now, with regard to children who have had previous myocarditis or pericarditis, if the previous pericarditis or myocarditis is unrelated to the COVID-19 vaccine, so occurred before they've had COVID-19 vaccination, then the recommendation is to consult with their clinical care team and follow the advice of that team. And if they're no longer under care for their myocarditis or pericarditis, then these children can be offered vaccine. Now, if the child develops myocarditis after a COVID-19 vaccine, and again, we don't know if this is going to be a concern or not, and obviously this is not going to happen right now because we're only offering first doses. This relates to second doses, but if it turns out to be children who do develop COVID-19 after the, do develop myocarditis, pericarditis after the COVID-19 vaccine, then they shouldn't receive their second dose at this time. They should wait, and NACI will provide additional recommendations on this in the future. And there are no recommendations in the NACI statement on additional doses or booster doses beyond the second dose at this point. So now looking at administration of the vaccine for children 5 to 11-year-olds of age, this is an IM injection, intramuscular injection, and the preferred site for this would be the deltoid. If that's not possible, then an alternate site is the anterolateral thigh. The 1-inch needle will be fine to use both in the deltoid and in the anterolateral thigh, and guarantees a good IM injection. If other needle lengths are available to you where you're working, just be sure that they are appropriate to be able to offer a true IM injection. So looking at landmarking on the right, what we're trying to do is get the vaccine right in the middle of the deltoid muscle, and a way to landmark that is to take the acromion process, which is the bony part that sticks out on the top of the shoulder, and go 2 to 3 finger breaths below that acromion process, and that should get you right in the center of the deltoid muscle. So now we're going to switch to talking about additional or booster doses for adults and adolescents. At the same time that we're offering the pediatric campaign, we will be offering adults and adolescents primary series if they haven't received that, but we'll also be offering additional doses and booster doses. So on September 10th, NACI recommended that adolescents and adults with severe or moderate immunocompromising conditions should be offered an additional dose. This is like a third dose in their primary series, and that additional dose should be offered at least 28 days after their second dose. On September 28th, NACI made a booster recommendation for residents of long-term care homes and seniors living in other congregate settings. And they updated those booster recommendations on October 29th. So on October 29th, they reiterated that long-term care home residents and seniors living in congregate settings should be offered a booster dose. As well, adults 80 years of age and over should be offered a booster dose. And that booster dose is 6 months after the second dose in the original series. NACI also said that there's some other groups that may be offered the booster dose, and that's adults 70 to 79 years of age, anyone who's received a viral vector vaccine, only viral vector vaccine, so anyone who's had 2 doses of AstraZeneca or 1 dose of Janssen, adults who live in Indigenous communities or from Indigenous communities, and frontline healthcare providers who had a short interval between their first and second dose. So these are people who may be offered a booster dose, again, 6 months from their original series. So looking at booster and additional doses for the general population, we don't know yet if and when we will need a booster dose for the general population, but it's quite possible that we will be needing booster doses for the general population. We don't know yet, though, when those will be. So we can do some planning, though, with regard to that based on when people receive their second dose. And we know that most Canadians received their second dose sometime in June or July. If we end up needing a booster dose 6 months from that second dose, that would put that booster dose in December or January. If, on the other hand, we go 8 months from the second dose, that would mean that most Canadians would be getting their booster dose sometime in February or March. So when we look at how that overlaps with the other campaigns, we know right now we're offering influenza vaccine and booster doses or additional doses to key populations. We are now about to begin our pediatric campaign, and so that will run for first doses from November into December. If we end up offering a booster dose at 6 months from the second dose, that would mean that our booster campaign would overlap with our first dose of the pediatric vaccinations. If, on the other hand, we end up offering booster doses at 8 months from the second dose, this will overlap with the second dose of the pediatric campaign, because as we've heard, NACI has recommended at least an 8-week interval for the pediatric vaccine between the first and second dose. So that could potentially overlap with an 8-month booster campaign. So just things to keep in mind for planning. In closing, for the final part of my presentation, I just want to provide 2 slides that give you a bit of a summary of how to use the 2 vaccines, the Pfizer vaccine, and on the following slide, the Moderna vaccine, in the various populations that are eligible for vaccination now. We know there's a lot of moving parts between initial series and booster doses and additional doses, and now pediatric doses. And these 2 slides just try to summarize it all in a sort of one place that can help keep some of the moving parts straight. So in the first column, we have the populations that are being offered the vaccine. In the next column is what formulation to use and the volume of diluent to be added. Next is the dosage to be drawn up in the syringe. And finally, the schedules to be used for the various populations. So this is available here for the Pfizer-BioNTech vaccine, and a similar slide here for the Moderna vaccine. Of course, here there's no diluent to be added, but it provides you the population and the dose and the schedule to be used. So with that, I will now turn the presentation over to Dr. Katie Burney, who will talk about pain and needle phobia management. Thank you very much.
Hello, my name is Dr. Katie Burney. I'm a clinical psychologist and Associate Scientific Director for Solutions for Kids in Pain. And really thrilled to be here today to speak to you about how to improve vaccine-related pain and needle fear management for children as we roll the COVID-19 vaccine out to 5 to 11-year-olds in Canada. One of the things that we know is that Canada is a world leader in children's pain research, but this knowledge isn't not often put into practice. And this is really critical as we look at this rollout of the vaccine to 5 to 11-year-olds, because we know that about 60% of children in this age group report some fear of needles. So it really is quite high. And that there are things that we can do both for immunizers themselves as well as for children and their families to make sure that this is a more positive experience that can impact children over the course of their lifetime. And typically it takes about 17 years for research to actually make it into practice, of which we think in this context, that's an entire childhood of children who are missing out on science that we already have. Our vision at SCIP is healthier Canadians through better pain management for children. And this has never been more true than the rollout to the COVID-19 vaccine, where as pain management increases vaccine confidence in children and their families, that through greater uptake of the COVID-19 vaccine, we can contribute to the better health of Canadians. Our mission at SCIP is to improve children's pain management by mobilizing evidence-based solutions through coordination and collaboration. So working in partnership with different health jurisdictions, different institutions and organizations, such as the Public Health Agency of Canada. Our outcome is to improve children's pain management within Canadian health institutions and in our communities. And in doing so, we contribute to less suffering for children and their families, less avoidance of necessary healthcare, lower risk of addiction and chronic pain in adulthood, less financial burden on people and the health system, and that Canada is not only a leader in producing pain science and knowledge, but also actually applying that and using that in practice. And it's, again, really important in this context because we know that needle fears actually can contribute to healthcare avoidance into adulthood, even though needle fears often start in childhood. So by increasing some use of some of these strategies, we'll be able to reach more people and ensure greater uptake. SCIP is a national knowledge mobilization network. So we're a national not-for-profit organization, and we have a hub and spoke model with 5 regional hubs across the country that work to create, build up, and leverage connections across Canada. We're also what's called a patients included organization, which means we have people with lived experience embedded throughout our activities and also in co-creating a lot of the tools I'll share with you today. So those have been created with youth and families to ensure that they integrate the science, but are also understandable and usable, as well as with healthcare professionals. But the real focus of what I want to talk about today is the science and the clinical practice guidelines around how we reduce pain from vaccine injections. And you may be familiar with this clinical practice guideline that was published in 2015 and led by some work by Dr. Anna Taddeo and her Help Eliminate Pain in Kids and Adults team. This guideline does look across the lifespan, but for the purposes of our conversation today, have really focused on the guidelines that apply to children in the 5 to 11-year-old age range. And you can see that these guidelines cross 5 different key areas. The first are procedural. So these are things that to consider as the immunizer in the context or the procedural context within which the vaccine is given. So to avoid aspiration, if multiple vaccines are being given, to inject the most painful vaccine last, and to suggest against any simultaneous injection. Critical are also some of the physical strategies. So we recommend that children are sitting up during the vaccine. It's never okay to restrain a child for the context of a medical procedure, including an immunization. But you can have the child sit on their parent's lap, hold them in a bit of a hug. The parent can do that, which can assist the child to stay still, but can also, and to hold their arm still, but can also provide a comforting hold, almost like a hug from their parent while the procedure is taking place. In addition to sitting up, their recommendations also suggest you can use an external vibrating device with a cold pack. So there is such a device that exists. For those who have a history of fainting from needles, using a strategy called muscle tension, where the child briefly tenses their abdominal and their trunk and their leg muscles for about 5 to 10 seconds, and then releases that and repeats that a couple of times, not kind of tensing the arm where the injection will take place, but being able to do that with other parts of their body to counteract the vasovagal response that can happen with fainting. The guidelines suggest against manual tactile stimulation and not to warm the vaccine before it's given. In terms of pharmacological strategies, topical anesthetics are strongly recommended. So being available to the family or letting the family know they can use ahead of time, a numbing cream. One of the things that's really critical to consider is obviously the time ahead that the topical anesthetic needs to be placed. So 30 to 60 minutes before the injection, depending on the product. So families need to know about that ahead of time often. The other misconception is that families sometimes think that they need a prescription for these products. So being able to communicate to them that this is something they can purchase over the counter for just a few dollars for a single time use. The guidelines suggest against vapocoolants, so those freezing sprays, and also suggesting against acetaminophen or ibuprofen before the vaccine is given, showing no benefit to vaccine-related pain from the injection itself. So being able to communicate that to families ahead of time, because that is sometimes a misconception that people hold. In terms of process guidelines, it's really important that we're educating about these pain management strategies for immunizers. So part of this webinar that we're sharing, but also being able to communicate this to parents and children who are being immunized. You can see many of these strategies require a little bit of preparation beforehand in the context of distress or coping for children. As parents are telling them about the procedure, letting them know, a couple of days ahead of time, or perhaps even a week for older children, that this will take place. It's often great to be pairing that with a discussion about the coping strategies that will be used or that will be available to the family. So being able to communicate this ahead of time is really, really important. And again, you can think about this in terms of integrating the evidence I'm sharing today, even in things like confirmation emails, when a family books an appointment for the child to be immunized. And the guidelines also recommend that a parent is present for children 10 years and younger. So thinking about what this means in the context of your clinic or your rollout plans in terms of the COVID-19 vaccine. And again, I mentioned the parent can play a helpful role in terms of comfort positioning, so sitting up, but also some of the psychological strategies I'll talk about. And then the last category is psychological strategies, and these ones can be quite helpful. For immunizers themselves, just knowing that recommendations suggest you should provide a verbal signal of the procedure and being able to do this in a very neutral way. So even such a thing as counting. So I'll count to 3 and then give the injection. 1, 2, 3, here we go, can be a verbal signal of the procedure, but is not using language that's likely to induce fear or further distress or anxiety for the child. So avoiding language like shot, or those kinds of words. One of the other very effective strategies is also distraction. This helps to occupy the child's mind and really allow them to pay attention to something else, which can reduce the perception of any pain from the injection, as well as can reduce some distress. This can be done just by verbally talking to the child about something else, their day, what they plan to do later, just what's going on, elsewhere. During their week. It really nothing specific, but just being able to engage them in conversation about something other than the immunization itself. But also videos can be very helpful if a parent is present. This can be things like a smartphone, being able to have a YouTube video or a game that the child is playing on the parent's phone, or just something else fun. Music can be quite helpful, or also breathing. The recommendation suggests breathing with a toy, such as a pinwheel. This may be more challenging in the context of masking, but encouraging children to take deep breaths while they're doing the distraction can be helpful. Avoid any suggestions that something is being done to help them if nothing is being put into place. We should be putting all of these things into place, but falsely suggesting or misleading the child is strongly recommended against. The other thing that we avoid or we recommend not doing is to avoid reassuring. And this is often instinctual, both for immunizers, but also for parents, to apologize or to say, I'm sorry this is happening to you, you'll be okay. We actually find in the research that this can actually indicate or inadvertently communicate to the child that there is something to be fearful about. So instead of reassuring, focusing on some of those distraction strategies, providing them some praise for how they are coping, and really redirecting them to what they're watching or their breathing instead. And then we suggest against just a cough. So some studies have looked at whether coughing at the time of the injection helps to reduce pain. And the science says that no, that is not sufficient. So really using some of these other strategies that I've mentioned. And again, being able to communicate some of this ahead of time to families can be really helpful so they can know what to bring with them, being able to use some of these distractors while they're waiting, either before or after, before they leave the clinic. I also want to make a comment about significant needle fears. So while the pain management strategies I mentioned should be in place for every child within this age group, and I did mention that needle fears, about 60% of children in this age group have some level of needle fears. Those range from low to very high. And it's actually about 5 to 10% of the population that have a very high fear of needles. And in extreme cases, what we would call a needle phobia, similar to other anxiety phobias, such as fear of spiders or fear of snakes. And it really induces a fight or flight response for these children. Or for adults who have a high level of needle fears. And in these situations, we actually really need a different approach. So these pain management strategies we've talked about are unlikely to be sufficient on their own. And this clinical practice guideline really focuses on what are recommended treatments for these high levels of needle fears or needle phobia. And what the science suggests is for children in this age group, exposure-based therapy is the recommended approach. And this is typically done with a mental health care professional who would guide them to gradually be exposed to and practice each of the steps in the needle procedure, giving time for that anxiety to reduce. If you have a child who has high levels of needle fears and has been able to engage in some exposure-based therapy, work in collaboration with the family to know, what you can do to be helpful. Often the family has then carefully considered what pain management strategies and distress strategies they would like to use. If not, be aware that, it may seem like a one-time procedure, but if a child is really showing a high fear response and the family or you are being asked to restrain the child in order to have the procedure done, to suggest that they might actually consider seeking support from a mental health care professional before getting the vaccine. This can be quite traumatic for families and actually lead to further needle fears and further healthcare avoidance if not treated appropriately. For people with higher levels of needle fears, also creating space, thinking about alternate options within the clinic, perhaps having a quiet area or an immunizer who feels more confident in immunizing children in this age group or in immunizing people with higher levels of needle fears can be particularly helpful. So those are options just to be aware of and to consider and to support families you see. And when I think about the context of the two vaccines, the 2-dose regimen for the COVID-19 vaccines for children in this age range, it's really important we're paying attention to needle fears as well as pain management, because we want and need families to come back for the second dose. And so really important that these things are put into place to further ensure that children will experience reduced pain and reduced distress when they think about coming back the second time. In terms of resources and such that you can use, with SCIP, we've been engaging in a number of different activities related to vaccines to assess readiness, to pull together resources and evidence, to create new tools, to facilitate change and also increase awareness and urgency about the importance of vaccine pain management and needle fear management in children and their families. We've done some surveys with Healthcare Excellence Canada, a national survey, which continued to show early on in the pandemic that needle fears and pain management were one of several contributing factors in which parents were considering their decision to get their child vaccinated or not. So knowing these things are in place can increase vaccine confidence and vaccine uptake. There are a number of tools and strategies that you can look to as an immunizer on our SCIP website, kidsinpain.ca. We do have the Making Immunizations Comfortable for Children and Parents Ask Me Anything highlight, which does have some, again, further resources and guidance using the strategies I've talked about today. But lots available, lots of videos we've created for parents and so on to ensure that they, as much as possible, they are also accessing this information. We've also been working in partnership with different organizations and health jurisdictions, including the Public Health Agency of Canada, across Alberta Health Services and across the country, in Nova Scotia and so on, as well as in partnership with the CARD program. And this is led by Dr. Anna Taddeo, who, as I mentioned, was the lead in developing those clinical practice guidelines. CARD stands for Comfort, Ask, Relax, and Distract, and is a strategy or a system that has evidence to suggest it can be helpful, including in school-based immunization clinics. So being able to ask children and their families to play their cards in terms of being able to best manage pain and distress from vaccines. We've also been in conversations with the media and a number of articles, live Q&As, including in the Washington Post and a recent article in the Globe and Mail, to really ensure that these strategies are reaching as many people as possible. And lastly, SCIP is working in partnership with Children's Healthcare Canada on a project called Immunizing Children with Confidence. And we will continue. Much of this is also to share information with immunizers and other healthcare professionals, including healthcare professionals where parents and families are going to ask for advice in terms of whether they should have their own child vaccinated. So including family physicians, pediatricians, specialist doctors, and so on. So keep your eye out for that as we continue to share more information over the coming months and the coming years. And if you'd like to learn more about SCIP and see more resources about vaccine-related pain management and needle fears, you can check out our website or follow us on different social platforms or sign up for our newsletter. Thank you very much.
Thanks, Katie. The Public Health Agency of Canada has produced guidance for public health authorities and personnel who are planning for pediatric COVID-19 clinics and multi-product clinics. This guidance is publicly available online, and I'll walk you through some of the content now. We'll start with pediatric clinics. Provincial and territorial health authorities have indicated that a variety of clinic models will be used for the pediatric vaccine campaigns across the country, including the models listed here. We provide some considerations for planning all types of pediatric clinics, and we have some guidance specific to school-based clinics coming up. When working at or planning pediatric clinics, we suggest creating a light, child-friendly atmosphere. Schedule appointments in advance to avoid large crowds and long waits. And if some wait time is inevitable, consider ways that the clinic can safely provide distractions or cue parents to keep children occupied in the waiting area to minimize anxiety during the waiting period. Minimize noise and avoid music, which can make it hard to hear and requires people to talk loudly. Budget for materials and supplies to adapt the environment for children by, for example, using colorful decorations and signage. Privacy can be provided with curtains, cubicle walls, or colorful blankets to separate immunization stations and prevent children in the waiting area from seeing others being vaccinated. Age-appropriate distractions can be provided at immunization stations. Consider objects or toys for children to hold or play with that can easily be cleaned between clients or that are single use, for example, stickers or printed coloring pages. Allow children to bring an item from home for comfort or distraction, such as a stuffed toy or an electronic device. And as a clinic planner, you can consider providing the Wi-Fi password so that kids can watch a show or YouTube video on a parent's phone without using up data. Consult with child life specialists or other experts to advise on environmental considerations, like setting up a private relaxing space for children who are highly anxious or have special needs. And ensure that there's adequate security for the safety of staff, volunteers, and clients, and to help with crowd control and clinic flow if necessary. We expect that the immunization rate at pediatric clinics will be slower than for adult clinics. For efficiency, siblings can be vaccinated together if they're eligible, and the least fearful sibling can go first. It's important to know that staff can take their time. In terms of training, we recommend that all staff at the clinic be trained in how to manage pain and needle fears and make children comfortable. Clinic staff should know age-appropriate distraction techniques and how to support children with developmental or emotional needs. Staff should also know how to respond in situations like a child attending with someone who is not their parent or guardian, what to do if an issue requiring child protection services is identified, and how to respond to adverse events in children. Next, we provide some considerations for school-based clinics. Not all jurisdictions will be using school-based clinics, but there are some distinct advantages to them. Schools are typically familiar to the community, easily accessible, and in convenient locations. School clinics can increase equitable access to vaccines and may result in higher coverage for some communities, and they're convenient for parents who do not need to arrange an appointment and transportation or take time off work. Clinic planners also may already have familiarity with this model from other school-based vaccination programs. And there may be some challenges to planning school clinics as well. School administrators or parent groups may not be in favor of hosting the clinic in the school. Families may prefer to have a parent present for vaccination. Consent forms may not be returned to the school, even if parents do want their children to be vaccinated. And school clinics can be time-consuming and resource-intensive and require considerable organization and planning. Among groups of students, there's also potential for spread of fear or anxiety. So it's important that clinic staff and school staff take students' fears seriously and are educated in how to manage them. Our pediatric clinic planning guidance gives additional details about what to discuss when collaborating with school administrators or the school community when planning. And one important consideration is whether parents can attend with their child for their vaccination at school. We provide guidance for communicating with parents and children about vaccination options. For example, we recommend educating parents about how to plan ahead for strategies to promote coping and to reduce fear and pain during school-based immunization, some of those strategies that Katie just spoke about. It's also important to let parents know what types of distractions or comfort items will be available at the school clinic or that children are allowed to bring to the school clinic so that families can plan accordingly. We also recommend providing advice to parents whose children may need extra support, such as having a parent present, if possible, at the school clinic, or alternatively, attending a type of clinic where they can be present with their child. We know that getting parents informed consent can be a challenge for school-based clinics. So school clinics can consider using electronic forms, consent forms, so that they won't be lost or forgotten in children's backpacks. On the consent form, we recommend obtaining multiple contact numbers for parents and guardians, and to consider collecting the weight of the child and the date that their weight was measured, in case this information is needed for epinephrine dosing in the event of an anaphylactic reaction. The consent form can also include a question about the child's past responses to needles or vaccinations. Having this information in advance can be useful for teachers and immunizers so that they can support children who have had difficulties with needles or vaccines before by, for example, sending them to a more experienced immunizer, using a more private space, or facilitating distractions. We also provide some considerations about clinic logistics. For example, the 15-minute post-vaccine waiting period can be done in the classroom. In terms of the immunization process for pediatric clinics, as Katie has mentioned, pre-immunization is the best time. So before anyone arrives at the clinic, that's the best time to inform parents about pain and fear management strategies so that they can prepare before coming to the clinic. So if parents are booking appointments online, you can use the booking confirmation email to provide tips and links to resources to ensure that the information is available to all parents. At the point of immunization, we suggest that all clinics have training and communication tools for immunizers, like job aids and quick reference guides, resources on pain management techniques, and that immunizers know where to refer families if the vaccination can't be completed at that visit. We also have guidance available online around how to manage pediatric dosing errors. Post-immunization, the waiting room should be child-friendly and promote positive associations with the clinics. So some age-appropriate entertainment can be incorporated and do keep COVID public health measures in mind. Tokens of congratulation for vaccination can be given out, like stickers or toys, but avoid providing food unless it's wrapped to go to prevent having clients remove their masks to eat inside the clinic. And please ensure that any food is free of common allergens like peanuts. As usual, post-immunization is when aftercare instructions are given, as well as information regarding when to come back for a second dose. Now we'll talk about some guidance for multi-product immunization clinics. These are clinics in which multiple vaccine products or doses are available at the same location. As we saw earlier in the presentation, concurrent vaccination campaigns are currently in progress and are anticipated over the next few months. Some health authorities and immunizers may have experience with multi-product mass clinics, for example, seasonal flu vaccine products for different populations. But not all clinic planners or staff will have experience with this, so we recognized a need to provide some guidance. Multi-product clinics certainly have some advantages. They're more convenient for the public. They may increase coverage for all vaccines being offered, and they typically require fewer human health resources than having separate clinics for each product. However, there's real potential for added complexity with these concurrent rollouts that target different populations with different vaccine products and different doses in some cases. Multi-product clinics may have increased risks of administration errors, with potential health consequences for the individual, and errors also run the risk of reducing public confidence in mass vaccination campaigns and vaccination more broadly. And multiple vaccination clinics at the same site may lead to public confusion. So these are all some things to keep in mind when planning a multi-product clinic. And we're going to walk you through a few possible organizational structures for these clinics that you might consider for planning purposes, or to orient you to the clinic setup that you might work in as a frontline vaccine provider. Model 1 shows a multi-product clinic with separate areas per product. So let's walk through the legend. In this clinic design, we have 3 products on offer. The purple is representing a COVID-19 booster dose or primary series vaccine for ages 12 and older. Orange represents a pediatric COVID-19 vaccine, and blue represents the seasonal influenza vaccine. So this diagram shows the client flow. Clients queue up, check in, and then they're directed to the area of the clinic that is designated for their vaccine. The pre-vaccine waiting areas, dilution and pre-drawing areas, and immunization stations are completely separate for each product. Ideally, the dilution and pre-drawing areas are walled off from other areas so that they are a safe space without distraction or contamination for preparing vaccines. An adult attending this clinic to get a COVID booster and a flu shot would walk in, check in, receive their COVID-19 booster dose in the purple area of the clinic, and then they would walk through the post-vaccination waiting area to enter the pre-vaccination waiting area for their influenza vaccine in the blue section of the clinic. And they would have their flu shot administered there by a different immunizer. Then they would wait in the waiting area for 15 minutes prior to leaving the clinic. This clinic design is the safest in terms of preventing vaccine administration errors, but it's also less convenient, potentially more confusing as well for clients and families requiring multiple products, and it requires more time and health human resources. Model 2 shows another type of clinic design with 3 vaccine products able to be administered by the same immunizer at each station. For safety and to prevent errors, each vaccine has a separate dilution and drawing up area. A family or an individual can go to one immunizing station to receive multiple products at once, such as an adult receiving a COVID-19 booster and a flu shot on the same date. Or a parent could receive their flu shot at the same station where their child receives their COVID-19 pediatric vaccine. This clinic model is more convenient for clients receiving multiple vaccines or for families. However, it's most prone to errors with the same immunizer handling multiple products. This model requires more experienced immunizers and more training time for new immunizers, and could be more stressful or taxing for immunizers. We also present 2 hybrid models. Model 3A here and 3B coming up on the next slide that have separate areas per product and a multi-product area for individuals receiving 2 vaccines at the same visit, or for families receiving multiple vaccines among them who would like to stay together. These hybrid models can be complex to organize and require more experienced vaccinators and more training for those working in the multi-product areas. But they maintain the safety advantage of separate areas per product for those who are receiving only one vaccine at the clinic. And they're more tailored to the needs of each client in that the family or client only queues up once. In hybrid model B, the gray multi-product vaccine area is slightly different. Rather than having the same immunizer give multiple products in the gray area, here we have multiple immunizers who are only administering one product per shift. So the family or individual goes to different stations sequentially within the multi-product area of the clinic. Having each vaccinator give only one vaccine in the multi-product area makes this version of the hybrid model safer. However, it's less convenient and potentially more confusing for families and individuals receiving multiple vaccines, as they would have to change immunization stations for each product. And there's uncertainty about the efficiency of this model. For all of the multi-product clinic models that I just described, we provide guidance for mitigating risks of vaccine administration error in the form of clinic design and administrative controls like policies and procedures. For clinic design, we advise to color code all items associated with each product. Colors may be chosen based on the packaging of a particular product. For example, the pediatric formulation of the Pfizer-BioNTech vaccine has an orange cap, so all signage, baskets, consent forms, and other materials could also be colored orange. Provide all staff with clear job aids that correspond to the color coding. As you saw in the clinic diagrams, separate dilution and drawing up stations are recommended for each product or dosage to prevent errors. You may also require that staff who are doing the dilution and pre-drawing work with only one product per shift to prevent errors. In terms of administrative controls, we recommend that the most experienced staff work at stations where the same immunizer is giving more than one product or dose, and that new vaccinators are paired with more experienced vaccinators for training in that role. All staff could be required to do an accountability check, like signing a daily quality assurance checklist to ensure that staff are aware of important information, any recent changes in processes, and resources and assistance that are available to them if they have questions. Policies and procedures should be developed to manage errors and to actively encourage reporting of errors or near errors so that appropriate client follow-up can be initiated, and so that the occurrence can be used as a learning opportunity for staff and contribute to improvements to processes, policies, and procedures. For further details, you can check out our guidance at canada.ca under the Guidance for Health Sector Preparation section. Content and links to additional resources from this presentation will be found in the Planning Guidance for Immunization Clinics for COVID-19. Thank you. And over to you, Katie, to wrap it up.
Thank you, Alex. And thank you to all our presenters for your truly fascinating presentations today. Should any viewers of this webinar wish to refer back to the information that was shared today, the presentation slides and a list of resources available will be provided on the CANVax.ca website. We hope that the information provided today will help you in your practice, and we'd like to thank all healthcare providers and those working in vaccination programs for your efforts during the COVID-19 pandemic. Thank you.